Good evening. Welcome to the MyCP webinar for Wednesday, October 30th. My name is Paul Gross, and I'll be your host. I'm excited to have Dr. Bhooma Aravamuthan and Michele Shusterman with us to talk about a whole breadth of progress that we've made around dystonia in CP. And so we're going to give you an update on that. I'm going to start, as usual, with an introduction to the CP Research Network. For those of you who dial in a lot, this is starting to be an ever-changing presentation, so you might learn some new things, be some things you haven't heard before. And then we'll dive into the presentation of our progress in dystonia and CP. And then Dr. Bhooma is going to do a little interview of Michele Shusterman to understand about our new dystonia in CP toolkit. Then we'll open the floor to Q&A. If you have a question as you're going, feel free to put it into the chat. We'll get to it when we open up the Q&A at that point. Okay, so I'm going back to trying to have people understand how we formed and why we formed the CP Research Network. So there was a National Institutes of Health meeting in 2014 that was entitled The State of the Science and Treatment in CP. And it identified a number of issues for advancing the state of science and treatment. One was to establish a national registry so that we could really track data to be used in research and improve outcomes. Second was comparative effectiveness research. So this is comparing two interventions. This picture is from Dr. Iona Novak's state of evidence paper, and it basically talks about which the green things are things that there's enough evidence to say they're effective. The yellow are probably good, but a lot of these interventions are interventions to achieve the same outcome. And so there's not enough work that's been done to compare them to determine what is the best solution. The other was to improve the study of adults. There's an estimation of there are 1 million people in the United States with CP. If that's the case, there are about 200,000 kids and 800,000 adults. And a lot of the research at that time was formulated around kids with CP. There was also an emphasis on the need to develop a research agenda for basic and translational research, to bring more young investigators into the field, and to create closer connections between patients, families, and investigators. And these were all detailed in an article that was published after the workshop, and then also in the NIH strategic plan for cerebral palsy. So the CP Research Network was really founded to do all of these things. The photo is from 45 of us gathered in Chicago in 2017 to set a patient-centered research agenda. And our mission is to optimize the lifelong health and wellness of people with CP and their families through high-quality research, education, and community programs. So we basically have 4 pillars to the work that we do. We have getting together to improve our research and quality improvement. The photo there on the left is a number of investigators and community members gathered in Michigan in 2019. On the bottom left, we have all of our educational programs, but we are going to be talking about a new thumbnail that needs to go there tonight for work in dystonia and CP. We have our health and well-being program in our partnership with the National Center for Health, Physical Activity, and Disability. I'll talk briefly about that. And then we engage the community in our work, and that's a big focus. So our vision we define as what we're trying to achieve in a 5 to 10 year time frame that is meaningful but achievable, is to engage the community and a vast number of health systems into what's called a learning health network, i.e. hospital systems that gather information on their treatment of their patients and using that information to improve the care. So a learning health network for CP that allows us to collectively focus the research and the care on the issues that you value most as members of the community. And those have been identified largely as being around participation and quality of life. So we gather and share these lived experiences from community members, and we also measure the healthcare process. Our goal is to be able to measure, are we making people healthier? Are we increasing their well-being? So that's the vision. And since we were founded, we launched the CP Toolkit in 2015 and have served more than 6,200 of those. That is entitled From Diagnosis to Understanding and was really intended to provide a lay language but evidence-based guide to the experience and the unfolding of the life experience of a person with CP. We went on to release well-being guides and translations of the toolkit in 2017 into Portuguese and Spanish. And we are going to be releasing the toolkit. Oh, that shouldn't say this month. That should say next month because we're on the last 2 days of this month. And then we launched MyCP, which is this personalized information platform built into CPRN.org. And then we also run these monthly webinars. We've been doing this for about 3 years to engage the community in research topics. On the research front, we were founded, as I said, to address those items from that NIH meeting. We launched a clinical registry, i.e. a registry that takes data from people passing through hospital systems and clinics, and then a community registry, which collects the experience of people living out in the community that are not necessarily patients at that time. And our clinical registry is up to 12,000 patients, and our community registry is up to almost 3,000. We published our patient-centered research agenda in 2018, and then we used that to focus our work. We've gone on to get some significant funding from the National Institutes of Health for our genetics research, and we've partnered with the largest private funder of CP research in the United States, the CP Alliance Research Foundation. We have 5 active quality improvement initiatives. Quality improvement is a way in which groups get together and they change systems within the hospital to improve outcome. And so hip surveillance, you're going to hear about some in dystonia, but hip surveillance is how do you make sure that kids with CP have healthy hips and that you intervene as necessary if those hips are becoming subluxated. We've had 16 publications, more than 45 academic presentations, and 5 manuscripts that are either in writing or in submission right now. So very active sort of academically moving the field forward in terms of the level of evidence. And now we're starting to do a lot of secondary analyses from that registry, i.e. we have all this data in the registry, what can we learn from it? And then we use that data to strengthen the position of our investigators in applying for public funding. And then on the wellness front, as I mentioned, we partnered with the National Center for Health, Physical Activity, and Disability to offer the mentor program. And we're hoping to work with them to expand that below the adult age that's targeted at, to offer it to kids. So just to give you a little bit of an idea of what's in a registry, so a snapshot from data back in May when we had a little over 10,000, you see the gross motor function classification system levels there and the percentages that we have across these 10,000 patients. That's one of the most important measures of how people move around the community. Levels 1 through 3 can ambulate independently or with an assistive device. 4s and 5s are wheelchair users, and it's a very important data point to have. And then you see the distribution of age. You can see about 25% of the people in the registry are adults, and 75% are children under the age of 18. So if you compare that to the community registry, which is collecting data out on the internet, you see a very different distribution of GMFCS or their ambulatory status. And then if you look at age, you see that we have something like 60% of the people that are in the registry are adults. So it's a kind of a very big difference between who's engaged in the community research versus who's passing through the hospital system. So we have, we're actually up to 34 centers, maybe 35. We've been growing, so it can be hard to keep track. The green pins are sites that are actively collecting data from their patient visits. If they have a circle, they're a lifespan center. They treat adults as well. The yellow pins are working through some of the technology of participating in our registry. The red pins are working on some of the compliance, and the blue pins are sites that have raised their hand and say, we want to join the network. You know, how do we do this? So we were really created, a big focus was to stimulate the research ecosystem because there just wasn't enough research going on and let 1,000 flowers bloom. So it's our focus on the research ecosystem is patient-centered. We build infrastructure to support investigators. So our registries, our network, our data coordinating center. And then we try to balance between generating evidence of improved care and improving care through these quality improvement initiatives. And then we can use this registry to monitor the effect that we're having from our work. Are people's outcomes improving? So the way we track a lot of this is with a pipeline. So we have this describes, Michele has said to me, we need the equivalent of how does a bill become a law? This is how does a study concept, become a study that actually executes. And so we have a process by which people propose concepts, they get developed into studies and they apply for funding, they get implemented and they execute. And then you take the data, analyze it, and write the conclusions. What evidence have you generated? And then you publish that to help everyone learn from that. So I'm going to run a little animation that just shows you how we've evolved to let 1,000 flowers bloom since we were founded in 2015, with the light green being children, the pink being adults, and the gray being lifespan studies. So you really get a sense of the work. There's a lot of work going on in the network, and the green ovals are our quality improvement projects. So in conclusion, the CP Research Network's sort of unique value proposition is providing this platform for sustained research and quality improvement, and really enabling the study of long-term outcomes, because most studies are funded to go out 5 years, but it's really important in CP to follow people long-term. And we're really creating a national learning health network for CP. So with that summary, I'm very excited to turn it over first to Dr. Bhooma Aravamuthan. There's a long list of accomplishments there for a very accomplished young doctor. Michele Shusterman, my co-founder, who's our Director of Education and Engagement and author of our educational materials. So Dr. Bhooma, I turn it over to you.
Thanks, Paul. I think the best sort of introductory comment you gave me is that I was a young doctor. Thanks for that.
It's true.
Well, I appreciate it.
If you don't know Romper Room, you're young.
All right. So I'll try and go through this somewhat quickly, because I really want to hear questions from y'all, and I want to make sure that we have time to really hear from Michele too. I have no relevant disclosures. Just in general, what we're going to try and go over for the rest of the time together is what is dystonia in cerebral palsy, and why are we even talking about it? And then 3 aspects of the community-centered research agenda for dystonia that Paul was talking about, and how we've addressed them through CPRN. So many people with cerebral palsy may be very familiar with the term spasticity, but what is dystonia versus spasticity, and how do we tell these things apart? So there are generally 3 forms of tone, of tightness you can have in your body: spasticity, dystonia, and rigidity. People with cerebral palsy very rarely have rigidity. If there are questions about that, I can take them at the end. But generally, most people with cerebral palsy, the majority of people with cerebral palsy, have spasticity together with dystonia at the same time in the same person. And these are the formal definitions of spasticity and dystonia, which I have up here for you to read. I explain them to my families a little bit differently, and to my trainees a little bit differently, and I think about them in this more practical way. Spasticity, I think of the type of tightness or tensing in your body that's there all the time to some degree. Now, you can have that tightness get a little bit worse, a little bit better, depending on, whether you're sick. Maybe you get a little bit more spastic. Maybe it's a little bit less when you're asleep. But if you have a set of muscles that are tight due to spasticity, they're going to be tight to some degree all the time, regardless of what's going on. And it is unusual for that tightness to be triggered. So it's not like you're going to be in a really stressful situation or try to make a movement and all of a sudden that tightness really kicks in those specific muscles. That would be unusual for spasticity. Dystonia is not that way. So dystonia is variable by definition. So it can be there for some period of time and then not there at all. So I treat kids primarily. There are some kids that have a lot of dystonia, and the muscles that are affected by their dystonia are very loose when they're asleep. So they'll fall asleep with their legs very relaxed and spread apart. But then when you're trying to change them, all of a sudden their legs get really tight and cross, and it's really hard to change or clean them or dress them. So that's one example where dystonia can get kicked in by someone handling you. Dystonia can also kick in if you try to make a movement. A part of your body that you do not intend to move can start getting tense. And it also can be triggered with stress, with intense concentration. So trying really hard to do a difficult task can trigger dystonia. And with pain can trigger dystonia too. So that sort of triggered variable tone that's there sometimes and not there other times, I think of that as dystonia. The type of tightness or tone that's there all the time to some degree, regardless of what you're doing, I think of that as spasticity. This is something called the Surveillance of Cerebral Palsy in Europe classification of cerebral palsy. And they really focus on this tone variability issue. So do you have tone that is varying? It's there sometimes and not there other times. And based on that, the general sort of breakdown for people with cerebral palsy is that you have spastic predominant cerebral palsy or dystonic or dyskinetic predominant cerebral palsy. Dystonia is the most common type of movement that falls under the dyskinetic cerebral palsy umbrella. And roughly that's, 85% of people with CP have spasticity as their predominant tone, 15% of people with cerebral palsy have dystonia as their predominant tone. And generally that was how it was thought of for a long time. But what we know now is that there's a lot of overlap. This is data from our center in St. Louis, and about 70% of our families have spasticity predominant tone. About 11% of our families have dystonia predominant tone. But if we just look at all comers, who has spasticity and who has dystonia, not trying to decide what the physician assessed version of predominant tone is, about half of our families have both in the same person. So just because you have a type of cerebral palsy that's called spastic cerebral palsy or spasticity predominant cerebral palsy does not mean you don't have dystonia. In fact, it's very likely you could have both spasticity and dystonia. Dystonia is often painful. It's one of the most common cited causes of pain in people with cerebral palsy. It's typically associated with being at GMFCS levels 4 and 5, so associated with more gross motor functional limitations. The data for treatments, particularly in cerebral palsy, is pretty limited, unfortunately. Overall, depending on the study, up to 75 to 80% of people with cerebral palsy can have dystonia. And diagnosing it, particularly in cerebral palsy, is unfortunately really hard. And a large part of that is because it's hard to differentiate dystonia from spasticity in people with cerebral palsy. When we thought about all of these things that made dystonia an important feature of cerebral palsy and something we needed to address, there were so many unknowns, and we know dystonia was so impactful, functionally impactful. The CPRN led an effort marshaling clinicians, researchers, and community members, people with lived experience together to prioritize what should we sort of attack first? What are the main questions we need to answer for dystonia and cerebral palsy? And we came up with the top 10 list that we published a little over 2 years ago. And here are the top 5. The first one, develop new treatments. I mean, of course, that seems like something really important to do. But there are other items on here that were proposed by a community member that I, as a clinician researcher, would not have thought of 2.5 years ago. So assessing the second priority, assessing rehabilitation and psychological management approaches for dystonia and CP. That's such a valuable way to think about it, particularly because dystonia can be triggered by stress and triggered by heightened emotions. And in the intervening time, there's growing data to suggest that treatments for stress and anxiety-based therapies and occupational therapies can be helpful for dystonia and cerebral palsy. So that second research priority was really forward thinking from the community members that contributed to this. So this was the top 5. And then the priorities 6 through 10 are here. I'll tell you that the priorities that we've really, let me see if I can get rid of these marks, clear all drawings. There we go. So the priorities that we focused on first were these 3. Priority number 4, improved diagnosis and severity assessments, was a top one for us because we can't do anything about dystonia unless we're identifying it and unless we can track changes. And then along with that, we really need to rely on families and the community to help us identify dystonia and bring this to the clinicians that they're seeing. And then with priorities 4 and 10, making some progress there, we kind of have a chance now of addressing priority 3, which is of the current treatments we have, assuming we can identify dystonia, families are aware of their own dystonia, and we can think about treating it. What treatments do we currently have that actually work? So I'll be going through these in order. There, starting with improving diagnosis and severity assessments. So we have a long ways to go here. For babies that have had neonatal brain injury, so these are babies that have something called hypoxic ischemic encephalopathy at term gestation and are followed in our clinics because we think they're at high probability for cerebral palsy. Only 30% of those babies in a high volume tertiary care center had their tone type specified by age 5. So early diagnosis of dystonia is a problem, but even later diagnosis, and this is in older children age 10 to older children and young adults age 10 to 20 years old, of all of the kids that we saw who were able to independently ambulate, so GM-FCS levels 1 to 3, we reviewed all of their videos in a clinic visit and said, this percentage of people have dystonia based on our sort of expert quote unquote review of their clinic videos, 3 of us, 3 movement disorder specialists. Then we look back at our own notes from that same clinic visit. So I look back at my own note from a clinic visit where there was a video taken, and then I sat on my high horse and, looked at the videos of people and said they had dystonia. Looking back at my own clinic note and the clinic notes of my colleagues, only 13% of the young people that we said had dystonia in the videos had that dystonia documented in their clinical record. And this is a pediatric movement disorder run cerebral palsy center. So what this suggests to me is that dystonia can be really hard to pick up on in a single clinic visit with a single clinician, and we all need help. We need help from families to bring this up. We need help from the people with cerebral palsy experiencing dystonia to bring this up, and we really need to be vigilant about it at every clinic visit. So with that in mind, when we started approaching the quality improvement effort for dystonia diagnosis, we thought about a multimodal approach, engaging the family and engaging our own exam and making sure that we prioritize looking for dystonia at every single clinic visit. So we created something called an EPIC SMART phrase, prioritizing 5 items. And this just means that there's a standardized checklist that we include in all of our notes, looking for different items that we thought would help us identify dystonia or give us kind of cues to say, make sure you do this to identify dystonia. 3 of these items on exam come from a tool called the Hypertonia Assessment Tool, which is free to download from Holland Bloor Review. The reference for that tool is down at the bottom. These are exam findings that your clinician can look for to identify dystonia and differentiate it from spasticity in people with cerebral palsy. The first item that we wanted to make sure we asked, in addition to these exam findings, was to ask people who were directly either seeing a person with cerebral palsy for hours and hours and hours every day, multiple days in a row, who are living this, or people with cerebral palsy themselves, to ask them, does your tone vary? Is it there when you're awake? And then, or do you feel like you're floppy, or do you see your child be floppy when they're asleep? Do you feel like your tone is really triggered by stress? Do you feel like your tone is really triggered when someone handles you, or when you try to make a movement, or when you concentrate really hard on a difficult task? Asking these questions are really valuable for us, because these clinic slots for us are really short. There's a lot of stuff usually going on in that clinic visit that we need to address. And sometimes those exam maneuvers are not going to catch the dystonia that's really impactful in your day-to-day life. So making sure that we asked families to describe variable tone, and if you're in a clinic visit, making sure if you experience variable tone, describing that to your clinician can be really valuable for picking up dystonia. So here's an example version of the SMART phrase in the notes that we use at St. Louis Children's. We used this documentation practice across 3 CPRN sites, and it took us a while, but eventually 95% of our visits started using this practice. So that's great. Part of the battle is getting people to do the same thing, to agree on something to do and then do it. So we were already really happy that we could do this. But then did it do anything? Like, what's the point? Did we all just change our documentation practices and nothing happened? Well, it turns out that when we started, we collectively across all 3 sites had a diagnosis rate of 52% for dystonia, which is roughly low compared to research estimates. So if you remember earlier, estimates based on research assessments of dystonia were somewhere between 75 to 80%. So we're really trying to look to push the envelope up to at least 70% for a dystonia diagnosis rate, if we're trying to match a research-based assessment and not just a rapid-fire clinical assessment. So we started out around 50%. We instituted this QI initiative, and we increased our dystonia diagnostic rate across 3 sites. So what this tells us is that this is actually increasing our vigilance for dystonia clinically. And theoretically, the main thing we changed was asking families. We should have been doing the exam at every visit anyway. Now there's some argument that maybe we weren't doing that in a standardized way, but the asking families part is brand new to practice for us. And it just shows, hopefully, this community how important your voice is in advocating for your own dystonia diagnosis. So a brief interlude on some work from my lab that is contributing to dystonia diagnosis. This is work from spearheaded by my postdoc, Michele Shusterman, looking at videos of people in clinics, some of the videos that we as physician experts analyzed. And he's recently put out a machine learning tool to look for automated leg dystonia diagnosis in clinic. So I show this to you just for you to know that quantitative dystonia diagnosis is coming, and it's something that we're really excited about, and we're looking forward to advancing in the lab. I've also so far talked about, physician experts looking at the videos, and what do physicians see and how do we quantify that? But physicians are just one group of experts, and I've already alluded to this. The community, people with lived experience, is another big group of experts that can tell us about dystonia diagnosis. And when we asked caregivers of children and young adults with cerebral palsy 2 questions, and I've written out those questions here. When you try to move one part of your body, do you move another part of your body without meaning to? And during activities where someone handles a part of your body, do you move a different part of your body without meaning to? If you said yes to both of those questions, or if those caregivers said yes to both of those questions, 92% of the people they cared for had dystonia. And if they said no, 77% of the people they cared for did not have dystonia. So just kind of thinking about these questions for yourself could hopefully help guide dystonia recognition in the clinic. You can communicate your impression of these questions to your clinician. And this is work led by my former mentee, now a wonderful physician at Northwestern, specializing in cerebral palsy and dystonia, looking at how caregivers describe their child's movements when they're analyzing those clinical videos. So again, I talked about how physicians assess those videos, and these are the expert assessments of these videos. We asked caregivers to look at those same videos and describe what they saw. And they are just as good, if not better, than any movement disorders clinician at describing these videos. Some of the really interesting things that I thought and that Laura thought that caregivers said was describing dystonia as appearing like a subconscious attempt to balance. So they noted that it didn't look like their child was trying to make these extra movements during any motor task, but it looked like their body was trying to compensate for a movement in some way, and it looked like they were trying to balance. The other thing the caregivers brought up was that whenever their child really was trying to focus or concentrate on something, that's when they saw all that extra tone kick in. So really valuable insights that we see in the clinic too, but that all of us can pick up. There's nothing special about my expertise. It's just in a different context. So just wanting to empower everybody on this Zoom call that this is something that you can recognize within yourself. Noting that, I wanted to highlight this newer dystonia severity scale called the Dyskinetic Cerebral Palsy Functional Impact Scale. A lot of dystonia severity scales have been criticized for not prioritizing things that are most important to the people experiencing dystonia, particularly in the context of cerebral palsy, which is why I love this scale, because it asks caregivers and people affected by cerebral palsy to assess the impact of dystonia on different functional domains. And here I've just shown some examples for sitting and standing. When we, and this is preliminary data from our center, when we asked families to do their own DFIS, so this is a caregiver facing or a person with cerebral palsy facing scale, so you fill it out at home with the understanding of what your own dystonia looks like. We had families rate their own dystonia. I feel like my dystonia is better. I feel like my dystonia is worse. And then they rated their DFIS score. So this is DFIS being worse than previous. This is DFIS being better. And you see there's a pretty good relationship between your own sense that your dystonia got better and your impression that, that your function due to dystonia has gotten better. So it's a good indication that this scale works. It's not yet in common use clinically, but I'll tell you that a lot of us are really excited about it. So this might be something else to bring up in clinic with your treating clinician as well. Okay, so next, moving on to what we're doing for effectiveness of current treatments. I'm not going to go into this too much, but I do want to let everybody know that the American Academy of Cerebral Palsy and Developmental Medicine has put out a new dystonia care pathway. If you were to Google AAC-PDM care pathways, you'll see a list of care pathways for guiding surveillance and treatment and management of different aspects of cerebral palsy. I would encourage you to do that. This dystonia care pathway very recently came out. And I just want to highlight one aspect of this, which is in individuals with CP and severe generalized dystonia at the bottom, at the very bottom where that arrow is, we suggest the use of clonidine and gabapentin. And this is based on admittedly very weak data, a lot of expert opinion. We definitely need more data. And as a part of that, via the CPRN, in preparation for looking at what treatments actually work to treat dystonia and cerebral palsy, which is an ongoing clinical trial design that we're trying to put forth through CPRN, we surveyed treating physicians who treat dystonia across the US and Canada based on membership in 2 different societies. And we asked them how they approach medication-based treatment of dystonia. So most physicians said they treated dystonia that was generalized, meaning affecting the whole body, and that was functionally limiting, which makes sense, right? You don't want to treat dystonia that's not causing any problems, that's just there. So these ended up being 2 really critical factors guiding whether any medications were discussed for treatment or not. And these were the medications that were typically used in descending order of frequency, with baclofen being first line. So baclofen is in fact one of the top recommended treatments in the AAC-PDM dystonia care pathway. But I would alert you to the absence of clonidine in the commonly used treatments across the US and Canada, even though it's suggested in the care pathway. So that's just another sort of call to arms for y'all that clonidine may not be on the radar for some of the clinicians that specialize in treating dystonia and cerebral palsy, or that specialize in medication-based management of cerebral palsy. And it's just something that I want everyone on the call to be aware of, to ask about if it's not something that you've tried before for your dystonia, as something that is now very well indicated in the most recent care pathway as something to try. I have this table up just mainly for it to be saved. So this is how physicians dose each of these medications, when they use it and why they use it, including indications and contraindications. Questions about this I'm happy to take, but this is mainly just for your reference. And then maybe the most exciting part of the session is the work that we've been doing to increase family awareness. And when I say we, I really mean Michele. So Michele is just a force, and she has spearheaded two really incredible efforts to make sure that families and people with lived experience are aware of how they might experience dystonia. So the first is this really incredible video. It's about 20 minutes long, and it features many different people describing how they experience this dystonia, either in their own bodies or as caregivers, how they view dystonia and the people that they care for. Really beautiful, rich descriptions of how dystonia has impacted their lives and what dystonia feels like. And what it looks like for them. So I would encourage you to watch this. And as I think Paul alluded to, the Dystonia and CP toolkit is near ready to launch, hopefully in the next several days, to fingers crossed. Michele, as many of you know, was responsible for the Cerebral Palsy toolkit, which I religiously link to in all of my clinic notes and pass out to my families. It's just a really practical guide and description of what cerebral palsy is. This is just a brief excerpt from the toolkit that I've screenshotted here. And I would love to hear a little bit more from Michele before we take questions from y'all about these really incredible resources for family awareness. So let me do this. Wonder if I should stop sharing so we can all rejoin. I'm not sharing anymore, right? We're back on the screen as a group. Okay. So Michele, if you wanted to unmute.
Yes.
Yay. So first of all, thank you so much for spearheading these resources. I cannot wait to share the Dystonia toolkit with my families. I know that I've already been emailing my families the video. Can you talk to us a little bit about what inspired you to make these resources?
Sure. So I'm the parent of a 17-year-old who has CP. And when she was born, I found that there was an absence of support and resources. And it was very difficult for me to feel empowered as a caregiver to support my daughter in her development. And I wanted to focus on identifying and bringing together information that would help me. And eventually I realized that I really wanted to put forth in energy into the community overall, because there was such a tremendous need. And I really believe that it's going to be through partnership between the community and clinician researchers. That's going to be our fastest and most meaningful way forward to improve the symptoms associated with CP. In dystonia, we have a lot of videos that precede our webinar tonight about our effort and the energy that has gone into trying to shine a light on dystonia. And interestingly enough, I took my daughter to a multidisciplinary clinic out of our state. I'm in South Carolina, and I took her to a multidisciplinary clinic in Maryland at the suggestion of another parent. And it was extremely helpful. That was actually the first and only time I ever heard the word dystonia associated with my daughter's movement. And it was never understood. She was about 3 when we went there from that point forward. And we always heard things as her parents about how unusual her tone was, how variable. And there was also some discussion here and there about, if we didn't truly understand the picture and presentation of our daughter's movement disorder or disorders, it was not going to be very clear what her surgical outcomes may be if we moved in that direction. So that was, as a parent, frightening to me. And I thought about all of the people in our community who were facing similar issues, and there was really very little information about dystonia on the clinical side, through your physicians, and then also as a community. So when we have these big deficits in information, I feel that it is vital for us to have a foundation, even if we don't have answers, to understand where we are as a community. What do we know? What treatments are available, if any, and what kind of direction can we plot forward that makes sense and will begin to help people find relief? Dystonia is very tricky, and I'm amazed by the diversity of how it impacts people. We have a lot of people in pain, and it's, I think, somewhat disguised or hidden. And those people need to have relief. So I feel that this dystonia toolkit can serve a number of purposes, can empower you to approach your medical care providers. I don't want people to be afraid to ask. If you have a provider that can't answer your questions about dystonia, there are resources in the dystonia toolkit where you can direct a provider, like to the academy care pathways. It is a way for us to advocate for ourselves as a community and understand what we know. And we have had several efforts in place to address this issue of dystonia and CP and lay the foundation for moving ahead. What is really incredible and illustrates the value of the CP Research Network is that it's a parent who brought this issue forward. And she said in her experience, there are many parents and adults with CP who seem to be impacted by dystonia, but she never heard much about it. And that just very sort of innocent statement that she put forward led to all of this activity and to change. And I want all of you to feel like that's a possibility by participating with us and in our activities, because you have the right to feel empowered about your own healthcare. And I think that, there's lots of goodies in there, and you can always email us or email me if you have questions. And we're trying to take a similar approach in developing educational materials, hosting webinars to move the field forward. And we have a lot of complexity in CP and a lot to untangle, but we're going to do it.
I see Paul Staunches has his hand up. Paul, you want to ask your question?
Well, first of all, thanks to everybody on this call, especially the three speakers. Dystonia was very enlightening to me. Totally unaware of it until I met Dr. Bhooma. 4 or 5 years ago. And I just have a couple, well, one key question, maybe a couple of subsequent questions. In terms of terminology, dystonia versus dyskinesia, is one a subset of the other?
Yeah, I can take that, Michelle, if that's okay. So
Absolutely.
so dyskinesia, so dystonia is a subset of dyskinesia. And dyskinesia can also include a couple of other movement types called chorea and athetosis. Chorea is small, irregular, difficult to sort of predict, tiny movements that can occur throughout your body. And athetosis is slow writhing movements that can occur in any one part of your body.
And I'm sure there's overlap on all these subtypes as well.
I'm sorry.
I'm sure there's overlap on all these subtypes as well.
Yeah. So, yes.
Because
So,
I've been diagnosed with chorea as well.
yeah.
Oh, wow.
So chorea, so when we see chorea or athetosis, a lot of the time you tend to see it also with dystonia. So they tend to go together. That's not always true, but most of the time it is. By far, the most common type of dyskinesia is in cerebral palsy is dystonia. So that can get confusing, I think, from a terminology basis, because I think a lot of people, including myself, unfortunately, will use dystonic cerebral palsy and dyskinetic cerebral palsy almost interchangeably, even though that's not technically accurate. It's just that most dyskinesia and cerebral palsy ends up being dystonia.
Thank you.
Can you explain what tone is, Dr. Bhooma?
Yeah. I'll try. Tone is the sort of baseline level of tightness in your muscle when you're completely at rest, when you're not necessarily trying to do anything. So you can have low tone hypotonia, and we see that a lot in people with cerebral palsy, and that tone tends to be low in the neck and in the trunk. So making sitting up and keeping your head up harder. And then you can have high tone in cerebral palsy. So that's tightness in your arms and your legs, which is usually where it is in people with cerebral palsy, but it can be in other places too. The tightness that you see with dystonia comes and goes, and it can be in any part of the body, including the trunk, the neck, the face, the arms, the legs. But classically, tone is kind of your baseline level of tightness.
Thank you. Who do we have?
See Amber with her hand.
Yeah. And then one in the chat. Want to go ahead, Amber? Do I have to do something?
No.
No, I
she's
just
probably
have to I have to unmute myself.
Okay. Hi,
Totally understand.
Amber.
Hi, how are you?
Good.
Yeah, I wanted to know, so how subtle can dystonia be? Because I'm assuming there's a variation here, and like, so I'm not quite sure what well, that's part of my question, but my other question would be, how are you educating physicians? Because I can't even find a physician or even somebody, either peers, clinicians and peers with CP that can give you a good definition of spasticity. So I'm just curious, like if like, for instance, I'll just use myself as an example, I guess. At rest, I am more relaxed, but like I've been diagnosed with spasticity. So when they do range of motion tests, sometimes, I might have not normal, but within normal limits. But then when I move, it's a whole different story when I'm upright. So how would you, what I mean? Like, so what are the subtleties of that if it's mixed, and how is it diagnosed? And like I said, how are you educating other physicians? Because I feel like we don't even have a good definition for spasticity, and that's the more predominant
Yeah.
symptom.
Can I
Okay.
say something about that real quick?
Yeah.
Okay. So this is actually something I really struggled with as I was working on the toolkit. How is it that I can convey meaningfully what dystonia is in comparison to other movement disorders and conditions? And it is so complex, and it just became worse the more I read. That I realized, like, you truly have to be an expert in some ways if you want a good articulated definition that captures all aspects of dystonia. But at the same time, like Bhooma or Dr. Bhooma said, we're really good at self-identifying by answering specific questions. So it's very interesting. There's a lot of complexity there.
On to you, Bhooma, for the rest of the.
Yeah,
Yes.
let me echo everything that Michele said. Yeah, I mean, I think it is hard. I think the more I learn about it, the humbler I become as a clinician, honestly, identifying or differentiating between spasticity and dystonia in the people I see. The question of can it be subtle? Yes. In fact, the word subtle was used to describe it in one of the original hypertonia assessment tool papers, that the triggered movements that you see can be quite subtle. That was the word that was used. So that can mean very small. That can mean that it's only there, sometimes for certain tasks. It can be hard to pick up. I will say your description of your own tone was really lovely. And I think sharing that sort of description with clinicians and asking, could this be dystonia, is maybe, I mean, for me, that could be much more informative in some cases than trying to elicit it in a certain way on exam. So I thought your description was a beautiful description potentially of dystonia. I think describing that to your clinician and saying, is this dystonia, could be valuable. How are we educating clinicians? In part through initiatives like this. I think the CPRN is a network of people that are all trying to learn from each other, people with lived experience, clinicians, researchers, the whole shebang. And we're trying bit by bit, giving talks, writing papers, really encouraging people to take care of adults with CP clinically, across the lifespan, and recognize that dystonia is an ongoing concern. So the work is ongoing. CPRN's leading the way. We rely a lot on people affected by CP, people with CP, to advocate for themselves and ask these questions, particularly as adults. So I would encourage you to do that in your clinic too. I think that description that you gave was.
Let me also acknowledge that Dr. Bhooma is doing a fair amount of work in the American Academy for Neurology to make neurologists generally aware of a broad array of issues around CP and whatnot. So it's a pretty big effort. Let me check in before we answer more questions. Dr. Bhooma, Michele, there are a few more people. There's some questions in the chat, but we're also at the end of our, top of the hour, 9 o'clock on the East Coast. I don't want to, I want to be respectful of everyone's time.
Let me do like a rapid fire chat answer, and then we'll see how much time we have left, if that's okay. I see a bunch of like quick questions in the chat. Is that okay?
That's fine. I guess while you're doing rapid fire, I know you can multitask. We'll let Chrisanne ask her question. She's got her hand up while you're rapid firing, and see if you can handle the multitask. Great.
Hi, yes, you're really close. My name is Chrisanne. First of all, I just want to say thank you so much for all the information. I have a nephew with CP, and he has dystonia as well. I actually have dystonia in my hand. I don't have CP, but it's very, very hard to find anybody that really even knows what dystonia is. It took me about 5 years to get diagnosed. So hearing what you guys are doing is really encouraging, just because a lot of doctors have no idea what this is. So I basically have 2 questions. Rigidity,
Mhm.
is that basically tense muscles? And if so, so I have dystonia in my right hand. Can dystonia after a long period of time cause rigidity in the neighboring muscles? Because originally I just had my right index finger was affected, and then slowly it kind of started affecting the rest of my hand. And now I have a lot of tense, my muscles are very tense in my arm and going all the way up to my shoulder. But it took about 4.5 years for that to happen. So is that something that you have seen with people that present with dystonia, that eventually the muscles surrounding that area become rigid?
So if it maybe, which is an awful answer, but depending on how much dystonia you have and how much of the time it's there, you could develop contractures at the part that is dystonic. For dystonia to spread the way you've described, we would say that's segmental, so in one segment of your body. That is, I would say, a little unusual. It could be worth talking to your clinician about what sort of studies might need to be done to assess that. I will say that for dystonia, the progression of dystonia across the lifespan, the best data we have on that is from cohorts that have been examined for scoliosis that suggests that, loosely, it's not the best data, honestly, but it suggests that the rates of dystonia increase in people as they get older. So it is possible, although we don't know this for sure, that dystonia increases, that there's a higher rate of dystonia in adults compared to children. But the spread in one body part, I would say, in my experience, is a little unusual.
Yeah, because this is basically what my hand does.
Yeah.
In my hand, and then I have extensions here, but now all along here, my muscles tense up, where it's kind of like I'm flexing all the time. So it kind of leads me, because I thought maybe that was unusual, but I was like, well, your body compensates. So I thought maybe that's why. But I think I also have a little concern that there's something else going on that maybe I'm just not being diagnosed with, because again, it was very hard to get a diagnosis originally. So that's why I want to ask that question. If you guys notice that, or if it's something I need to look into further. It's very hard to find doctors who even know what it is versus even how they can help me.
Yeah. It sounds like, I mean, I say this very flippantly, right? Like a neurologist would be a great person to evaluate for that. I know it's hard to find a neurologist to see to see an adult with cerebral palsy. I know from my own experience referring my families on. But it does management of tone across the lifespan. There is a really big role that a neurologist could play in that. And so finding someone who can help differentiate between spasticity and dystonia and manage those things is important.
Gotcha. And then did I define rigidity correct, that it's basically tense muscles, or is it defined differently?
Yeah, so rigidity is differentiated. So spasticity is when you have, and this will make sense why I bring up spasticity. So spasticity is when you stretch a muscle at a joint, you experience a certain level of tightness, but then when you stretch it really fast, it gets tighter. Oh, there's my 4-year-old in the background. Rigidity is your muscle staying tight no matter how fast you stretch it. So it's tight regardless of the speed of stretch. In older people, so in people with Parkinson's disease, that sort of Parkinsonian, that's how we describe it. So in people who are Parkinsonian, rigidity is a common feature. It's rare to see rigidity in children with cerebral palsy. We don't really know about the evolution of rigidity in people with cerebral palsy as they get older. So I can't necessarily say that's unusual or not. It's something that we really need to work on studying.
Gotcha. And then my last question is really quick. So with baclofen, I started taking baclofen, but I'm pretty sure it caused chest pain. So I've been starting to wean off baclofen to see if the chest pain would go away. And it seems to be getting better. So it seems like it's the baclofen. If that being the case, what would be, because I know that it's a muscle relaxer, so what would be the best alternative for me to try? Because it does help relax those muscles in my arm. I obviously don't want to deal with chest pain all the time because that's scary.
Yeah, so this actually allows me to answer another question in the chat that Michelle already sort of answered. So in the AAC-PDM care pathway, there are, for dystonia treatment, there are a couple of branches. One is for dystonia that's affecting one part of your body. And obviously I can't I can't provide direct medical advice in this Zoom call, obviously, but in general, generally speaking, oh, and my 6-year-old's here too. So if there's dystonia affecting one part of your body, the recommendation is to try a focal injection like botulinum toxin.
Okay.
If there's dystonia affecting your whole body, the general recommendation for people with cerebral palsy is baclofen first, and then maybe to consider clonidine and gabapentin as other pharmacologic agents.
Gotcha, that definitely helps. I have it in some of the toes on my right foot, so I'm pretty sure it's the MS dystonia. So thank you for your answer. I really appreciate it.
Sure.
Let me pause us there. Bhooma, I see that your children are there. I don't want to everybody greatly appreciates your time and whatnot. There is one more question. I don't know if you have time to take it. If you don't, it's okay. We can follow up an email. Up to you.
Should we do one more question? Yeah, let's do one more question.
Okay. The question was from Caroline. It's in the it is both in the chat, but my question is whether or not you can have CP diagnosis and other diagnosis that can make it more complicated in treatment. I'm super curious about the use of Cinemet with CP.
Oh, what a great question. So yeah, you can have a cerebral palsy diagnosis and another diagnosis. And let me clarify that. Cerebral palsy is a collection of symptoms that you experience. So it is what I call a symptomatic or a clinical diagnosis. So it can be due to many different causes. So with the CPRN actually, and with Paul and Michelle, we published a paper using the MyCP registry, trying to understand how families and adults with CP would view having both a cerebral palsy diagnosis and what's called an etiologic diagnosis, or the cause of their cerebral palsy, together. And ultimately, we learned that people liked having the cerebral palsy diagnosis and also like knowing what caused their cerebral palsy, which is not groundbreaking, but sometimes you need to put these things on paper with numbers in order for people to believe you that it's true. So you can have cerebral palsy due to many different things, including in many cases, we know certain genetic causes of a cerebral palsy phenotype is the word that we use, or cerebral palsy symptoms. It turns out that when we asked physicians who treat cerebral palsy symptoms with medications, that many of them used carbidopa-levodopa, or one of the brand names is Cinemet. So used carbidopa-levodopa to treat dystonia that they saw in people with genetic causes of the cerebral palsy symptoms. What we have data on, though, is that carbidopa-levodopa in general across all people with cerebral palsy, and that includes people that have brain injury to specific areas of the brain on which that medication would act. So across all comers, carbidopa-levodopa is generally not effective to treat dystonia. But that doesn't mean that there isn't a subset of people with cerebral palsy for whom carbidopa-levodopa would be helpful. With all of that said, in my practice, in line with the AAC-PDM dystonia care pathway, I don't use carbidopa-levodopa as a first-line treatment. I use the other treatments that I just outlined, but I will use it as a second or third-line treatment depending on the cause of someone's cerebral palsy for dystonia treatment.
I just hadn't heard of anybody with CP getting that treatment. My daughter originally had CP and recently was diagnosed at age 16 with spastic paraplegia 50, which is a progressive degenerate condition, and has iron deposition in the brain in the same place as Parkinson's is found. So that's why the Cinemet works for us, and it really reduces tightness so that I'm not getting injured trying to help her even get into a wheelchair.
Yeah.
But it was more like we had tried it before, and I asked the question again. It wasn't that it was recommended. It has been a great godsend for us. So
That's
I was just surprised.
Yeah.
Yeah.
So, I mean, I think that highlights exactly what I'm trying to communicate, right? So for people with that kind of genetic cause of CP symptoms, I think carbidopa levodopa is back on the table. Usually after baclofen, after some of those other medications, we will try it for exactly the reasons that you outlined. So thank you for sharing that.
The reason
Well,
I asked the question I asked was because I'm concerned that sometimes when we do research and you have multiple things happening, it's very hard to really get data that's clear and distinct. And that's why I asked that question. Thank you for your answer.
Thank you.
Okay, I want to wrap us up because we're quite a bit beyond the time. I really appreciate Dr. Bhooma and Michele staying on. I really appreciate this presentation and all of the great work that you're doing as a clinician researcher, Dr. Bhooma, and all the great work you're doing, Michele, trying to make all of this information clear to families. I do want to thank Neurocrine Biosciences, who is the sponsor of our DCP toolkit and the videos that we did. So that really supported us being able to get out there with those, with that new information, those new media forms. And so anyway, so thank you both, and thank all of you for attending, tuning in. If you haven't joined MyCP, please consider that. It's a great way for you to sort of share and contribute on moving the field forward. It's great having you all tonight. Thank you very much.
Thank you.
Thank you so much.
You're
Thank you.
welcome.
Thank you.
Bye-bye.